When Dave Terry started his career in healthcare 3 decades ago, he noticed something odd and disturbing. The fee-for-service model meant doctors were paid for quantity, not for quality or cost-effectiveness. Since then, he's been working to do something about it. For the first 20 years at APM, Partners, and Harborside Health. He made progress, but he also learned the limitations of acting against entrenched interests. For the last decade, he's gotten even more serious, co-founding Remedy Partners in the wake of the Affordable Care Act, and then Archway Health, where he's CEO. Archway helps physicians jump into the meaningful, risk-based payment models that are finally on offer from the feds and private carriers. I compared Dave's quest to the 30 Years' War, but reminded him that there was a 100 Years' War too, so he better gird himself. I'm your host, David Williams, president of strategy consulting firm Health Business Group. Thanks for tuning in, and remember to subscribe to Health Biz. Well, Dave Terry, welcome to the Health Biz podcast. How you been?
I'm good, David. Thank you for inviting me to participate. Excited to be here today.
Listen, we've known each other for quite a while, but for the listeners who don't know you, what's your background?
Yeah, so I've been in healthcare my whole career since 1990, believe it or not, and started out of college with a healthcare consulting company, consulting to provider organizations, healthcare systems across the country. Did that for about 6 years and just learned a tremendous amount about the healthcare delivery system, how providers get paid. Really for the last 30 years, we've been in some form of payment reform, one way or another over that time period, kind of ups and downs for sure. But our business, when I first started, was helping providers get ready to take risk and think about, HMO contracts, capitated contracts, Medicare Advantage. We called it Medicare Plus Choice back then, but Medicare risk programs. And so my whole career really has been, thinking about how providers can take risk in different ways and manage care and manage risk in different type of payment mechanisms.
So you did a few, you worked for a few different places. I think I remember you were working for Partners Healthcare probably back around 2000 or so, and then where did you go from there?
Yeah, so I was in consulting for a long time, working with providers to in merger and acquisitions, physician relationships, building academic medical centers, or kind of building community relationships, affiliating with community hospitals. And then I went in-house basically and did that same type of work for the Partners Healthcare system. That was in the late 90s to the mid 2000s, and helped build the Partners network of community hospitals and physicians, help negotiate risk contracts with commercial plans and get into Medicare risk programs, and then also worked with providers to manage risk in various ways with technology tools and data and disease management companies. After that, I worked for a company called Harborside Healthcare, a Boston-based long-term care company. Harborside was a private equity-backed, basically skilled nursing facility business. I helped start our home care and hospice businesses at Harborside, and in our home care business, we created a risk program partnering with Medicare Advantage plans to help patients stay home and avoid readmissions and long skilled nursing facility stays and those types of things, and kind of age in place using nursing services and technology tools and those types of things. There's a lot of businesses that have had some success in that area the last several years, like Landmark and Signify and others. So that was a precursor to that. And then, when Medicare created the bundle payment program, bundle payment for care improvement, which came out of the Affordable Care Act, that program really got launched in 2011, or at least initiated in 2011. I jumped into that right away because, my experience working with primary care physicians to manage risk and post-acute providers to manage risk, the missing piece was really focusing on patients who need specialty care and going to, get care from an orthopedic surgeon or a cardiologist or oncologist or a gastroenterologist. And, the data that we had indicated that 70 to 75 of healthcare spending happens when people are sick, shockingly. And when they're sick, they're with specialists. And, I've done a lot of work with accountable care organizations over the years and different types of primary care attribution, risk attribution models. But even today, with the exception of folks who are participating in these bundle payment programs, most specialists are paid on an RVU basis. And If you got a primary care group that's trying to figure out how to manage care, but the specialists are paid on volume, the hospitals are paid on DRGs, the alignment isn't really there. And so what I loved about the bundle payment program was it creates more alignment, more opportunity for specialists to be engaged and to do well when they're effective, and to not do so well when they're either not great at what they do or not good at managing the overall, cost of care.
You should point out that the R in RBU does not stand for risk. That's not how the specialists are paid for.
Right.
More of a productivity measure. Going back to those days at Partners, I remember one reason I remember you were there at the time is when I left Boston Consulting Group and started up my own practice. One of the things that I needed to do as a small business owner was figure out what health insurance I should get. And I asked my doctor, what insurance did he want to take? I talked to fellow entrepreneurs. I talked to brokers. And I remember talking to you and asking if you had an opinion about it. And what you said at the time was, well, they're all basically the same, but at Partners, the only one we pay any attention to is Blue Cross. So anyway, I chose Blue Cross, and I've actually stuck with them since, based on your advice. I don't know if you remember giving that advice, but that's what I took away from the call.
I hear that story. I don't remember hearing that advice, giving that advice. I think that's true. So, but interestingly, I started my business several years after you started your business, and I went through that same process. And I think I'm much more frugal than you are, David. But I chose the healthcare plan that was owned by Partners at the time. So when you were doing this, Partners didn't own neighborhood health. Right, they bought Neighborhood Health Plan. Neighborhood Health Plan was really more focused on the Medicaid population and the kind of lower income population. But when I was choosing, Neighborhood was available, and it was the premiums were lower, but I was pretty confident that Partners wasn't going to restrict their network. So at the time I chose Neighborhood.
Well, good. Well, it makes sense. Well, it's a family affair, Dave. So even if I'm frugal, we do have to keep peace in the home here. So Blue Cross it is at my house.
There you go.
Good. So listen, you talked about a few different concepts, and one you've been mentioning is risk-based care and BPCI. And why don't we just step back and talk about, sometimes the concept of value-based care? I don't know if that's a term you use, but what is that, and what are the different ways that it's implemented?
Yeah, good question. So the best way that I think about value-based care is in contrast to fee-for-service. So in fee-for-service, everyone gets paid for what they do. It's really like piecework. There's no incentive to be coordinated. There's really no incentive to deliver value for what you do. Unfortunately, it's really just deliver a service and get paid for it. And in value-based care, the idea is that there is some aspect of value in the way that the providers get paid. And there's all kinds of different mechanisms. There's global capitation, which is kind of an accountable care organization. There's bundle payments. There's carve-outs. But at the end of the day, it's paying the provider to deliver not just the service, but to deliver the service with some quality component and some value-based cost component. And that's really the way we think about it.
Got it. And, would you say it's been, you said that these concepts have been around for a while, and I guess it was coming out of the Affordable Care Act passed in 2010, and then, 2011 when things started to happen. Has there been a real implementation of it, or is it just more of an awareness? And is it all coming from CMS, from the government, or where else are we seeing value-based care?
Waiting for value-based care is sort of like waiting for Godot. He's always coming, but you're never quite sure where, when he's going to show up.
I thought it was pronounced Godot, but okay.
So, as I mentioned, I've been doing this type of work since 1990, and I'm an optimist by nature and been hopeful that it's coming our way. But certainly the predominant way for providers to get paid is fee for service, and it's been fee for service for as long as I've been in healthcare. There have been different kind of fits and starts with different types of value-based programs and risk models coming to the market. I think where we are today in 2020, the biggest catalyst for this is a combination of the Affordable Care Act, which was passed in 2010, and the economy. Where healthcare is something around 19% of GDP. That questions around how much more of GDP it can be from the government's perspective and from employers' perspective. And certainly Medicare is the biggest driver of this. They hold more healthcare risk than anybody in the country. They're the biggest payer in the country. And Medicare has over 50 different value-based care demonstrations and programs that they're implementing right now. So they're pushing this in a pretty big way. And on the commercial side, Medicare Advantage plans are have different value-based contracts as well. And then in the kind of traditional commercial market, it's certainly spottier, but picking up in different markets. But we still have a long way to go. I saw some statistics. I think 25 to 30% of Medicare beneficiaries are in some sort of value-based arrangement, whether they know it or not. But we think it's going to pick up for a variety of reasons, but it's still nascent, frankly.
Now, you focus specifically on BPCI, which you mentioned before, and there's all the kind of alphabet soup coming out of Washington. I think we went from BPCI to BPCI Advanced. But can you talk about what is BPCI? How does it differ from the other programs, and why is that your focus?
Yeah, so at this point, we're underwriting any type of value-based care program. So we do a lot of work in the BPCI, the Bundle Payment for Care Improvement, and the Bundle Payment for Care Improvement Advanced program, and other bundle payment initiatives. But we also now do a lot of work in accountable care organizations and with employers. And so we're really focusing on underwriting risk, that healthcare risk that anyone wants to take. So if a provider wants to take that risk, or if an employer wants to be self-insured, we'll provide them with a stop-loss product. But we did start in the BPCI program. And the reason we started there is kind of what I mentioned before. 70 to 75% of the healthcare spending happens when people are sick and with a specialist and in some sort of acute or chronic episode. And so we wanted to become knowledgeable about how to improve care for patients who are getting specialty care and how to manage the costs during those episodes. And once we learned that, we started applying those tools and the data and the technology to underwriting all types of risk.
Got it. And if you think about the these risk-based arrangements, you said certainly the specialty care, and when people are in an episode, that's a good fit. Where do you see the real sweet spot? I know that BPCI has work in cardiac and GI areas and critical care and orthopedics. Talk a little bit about what those are like and maybe some of the nuances from one specialty to another, assuming there's differences in how it's managed.
Yeah, so let me talk about kind of on a macro basis and then on a micro basis. On a macro basis, what creates the opportunity in any of these areas is variability in performance. And when we look at providers across the country and within regions, we just see a tremendous variability in the quality of care, the outcomes that are delivered on a health risk adjusted basis, and in the cost of care. And we see that when we look in cardiology or diabetes or kidney care or oncology or orthopedics. That variability on the quality side and on the cost side is prevalent all over the place. And I think that's endemic to fee for service, where people are charging what they're charging and getting paid and not coordinating as much. And so the first thing we look for is variability. So we look for volume. Is there a lot of this care being delivered? Then we look for, is there a lot of variability in the outcomes and the quality and the costs? And if there are, then we'll look to see, among all that variability, who looks like they're doing a really good job, and what is it that they're doing that differentiates them from a quality and cost perspective. And we try to learn from those folks. And we do a lot of benchmarking. We do a lot of outreach to specialists who look like they're doing good work at volume for reasonable total cost. And frankly, we see that pretty much everywhere. In Medicare, the variability is driven mostly by, certainly variability in the quality of the outcome, but also the variability utilization of services. So if you look at orthopedics, for example, lots of variability in utilization of post-acute providers like therapists and skilled nursing facilities and inpatient rehab centers, and some variability in readmissions. If you look at cancer, variability in utilization of hospitalization rates and ER utilization, certainly lots of variability in drug spend, because drug pricing is not super rational. So there's opportunity there. The other area that we see opportunity in is in alignment. So the incentives for providers aren't fully aligned with the quality and the value from a patient's perspective and a purchaser's perspective. And so we try to combine our insights into the variability with promoting more alignment for better experience, better care, and better cost. And those are the things that really kind of drive value.
That makes sense. And then in terms of your own services, you talk about being a stop loss. So if I understand that right, it means that the provider's taking risk, but beyond a certain point, then you step in, and therefore you're aligned in that you're trying to prevent the risk from getting out of control to the point where you have to stop it. That's a simplistic version. Is that about right? Or how would you describe your role in this whole system?
Yeah, I would say there are three things that we do. One is, as you said, there's alphabet soup of all these programs, and there are over 50 different programs that Medicare has created. And then you layer in, commercial contracts and different types of carve-out companies and things like that. So there's tons of different programs and contracts that a provider could participate in as they move into value-based care and start thinking about taking on risk and sharing risk. So the first thing we do is we analyze all the programs, and we have a perspective on how they work, what the opportunities are, what the risks are, and what the keys are to success. And if a provider is thinking about getting into a particular program, we can help them understand if that program is a good opportunity for them, or if there's too much risk or too much downside. The second thing we would do is if they do get into a program like the oncology care model or a next gen ACO or a kidney care choices program, they're taking on risk. And we talked to a provider the other day. They've got $70 million of exposure if they have a really, really bad year, but they never want to write a check of more than $8 million in a year. And so now they've got a lot of upside. In addition to that $70 million of exposure, they may have $100 million of upside opportunity across their health system. And so it's a reasonable proposition. It's a reasonable business proposition, but their CFO is saying, if we lose more than $8 million, it's going to be terrible for us. And so we'll say, okay, you've got an $8 million deductible. For a premium of X, we can provide you stop loss, and so that facilitates folks understanding these programs and getting into them without taking risk beyond what they're comfortable taking. The third thing that we do is once they're in a program, we help them succeed. We don't do the work for them, but we have a lot of data. We show them what their performance looks like. We show them where their opportunities are for improvement. We show them that information on an ongoing basis. And then we provide kind of coaching and support to help them perform within those programs so that they can, gain upside, not have downside, and then also, less altruistically to make sure that, we're not paying out our on a claim if we can help them manage and be successful and deliver better care.
Yeah, absolutely. Let me ask you about this a little bit from the patient perspective. So you mentioned that, some fraction, 25, 30, 35%, whatever, of people in Medicare are going to specialists that are under some sort of a risk-based arrangement, and they may not know it. Now, would they actually see something that's different? Is a patient who is in one of these programs or who's physician in one of these programs, are they treated differently? Is there anything they need to watch out for? Any particular benefits they get out of it?
Yeah, I'd say there's a number of different benefits. So one. We have services, and we encourage our provider partners to increase the level of engagement they're having with their patients who they're caring for, right? So in a traditional healthcare experience, my experience, and I think most people's experience is you see your provider when you're in their office or when you're, if you have to be in the hospital, you're engaging with the healthcare system. But when you're home, you're kind of on your own. And in these programs, we're doing risk assessments as these patients go through these programs and trying to identify who needs more help. And for folks who need help, we're following up with them. We've got some technology tools where we can track how they're recovering relative to what's expected. We have nurses who reach out and call them, and we collect. We try to collect information on how they're doing, and then we also partner with the providers to follow up and encourage follow up visits and those types of things. So there's that level of activity. Trying to make sure the patient is not kind of dropped as they're handed off to the next provider, but there's continuity in the care and the follow-up and those types of things. Now there's a balance here because, people who are doing fine get annoyed when they get called too much. And so we want to make sure we're, helping the people who need it and letting the people recover who are doing just fine. So that's one. The second thing I would say is this creates opportunity for a lot of innovation as you get providers thinking more about, how their patients are doing throughout their healthcare experience or their disease experience, not just when they're in front of the doctor. And a couple of different examples. So we do a lot of work in cancer care with thousands of oncologists across the country. And, in our data, we saw that the biggest driver for hospitalizations for patients with cancer is sepsis. And, patients are on chemo, they're immune suppressed, they're getting infections, and they're getting them into the hospital. Believe it or not, none of the oncologists we work with knew that was the biggest driver of hospitalizations. They knew their patients would get infected and they have sepsis and things like that, but they didn't know it was the biggest driver, right? So now we're working with our oncologists to preempt and avoid sepsis and recognize that this is a risk and what do we need to do to avoid these types of infections. So we're not going to eliminate sepsis for patients on chemo, but we have reduced it. And so obviously sepsis is, I think, the biggest cause of death.
It's a killer, yeah.
So because we now have more longitudinal data, we're coordinating care across types of services. Typically, a patient who has cancer, if they get sepsis, they'd see an infectious disease physician or go to the hospital, and the oncologist might not even know that their patient had these issues. Now we're coordinating across those things. Second thing we saw, the second biggest cause of hospitalizations for patients with cancer is cardiac related. We do a lot of work with oncologists. We do a lot of work with cardiologists. We've put the oncologists and cardiologists together to start thinking about, why that is and how to manage that in more proactive ways. In orthopedics, we found that people do better when they get home faster, but the incentives are set up for folks to stay at skilled nursing facilities longer than they need to. We've worked to get people home faster, get them doing outpatient therapy more quickly and more sooner after their discharge, avoiding skilled nursing facilities. That reduces the cost, but also people seem to recover faster when they're home if that's an appropriate setting for them. So there's a whole variety of things that we've seen that not just reduce the cost, but improve the experience for the patient, improve outcomes, and reduce complications.
I think in our kind of polarized and superficial and hyper-partisan political debate these days, the Affordable Care Act is sometimes just equated with, protects pre-existing conditions on the one hand, and it requires an individual mandate on the other. There's much, much more to it. And as you mentioned, the BPCI and other value-based programs have come out of that. So, obviously we're in a point where went from the Obama administration, when he started off, we've had the Trump-Pence administration. We may have a change of administration again. How much of a factor do you think that will be for value-based care and for your business, depending on, the outcome in November and into January or whenever the fighting stops about who will be the president?
Yeah. So this is a good question. We get this question a lot, and I don't like to advertise it too much, but because by advertising it could change. But value-based care, I would say, is one of the few areas where we've seen significant bipartisanship and, frankly, a continuation of the momentum that was started in the Obama administration has continued to the Trump administration. The reality, and we've talked to folks at HHS and CMS in both administrations, and the reality is, costs are going up. The population is aging. The economy can't afford it. The government can't afford it. Can't afford, continuing on the fee-for-service model. And so the Obama team and the Trump team have continued to look for ways to move away from fee-for-service toward value-based care. And frankly, the Trump team has really kind of accelerated this at some level. I think the Obama team started with, wanting to move providers into value-based care arrangements, and they had incentives and programs to do that. The Trump team has kind of doubled down and said, their goal is in the next 5 years to have 100% of providers in some sort of meaningful downside risk arrangement in Medicare, some sort of meaningful downside Medicare risk arrangement, and 50% of providers in a meaningful downside commercial arrangement. And that's an acceleration of what the what the Obama team was doing. So, our view and what we're seeing in the marketplace is one way or another, this is coming. I think the economy demands, and it's not all about the money. It's also, healthcare is one of the most frustrating experiences and lowest kind of net promoter score industries that we have in this country. And folks are frustrated and spending more and more money on it. And I think, these programs created the opportunity to improve the patient experience, improve quality, manage for value. And we expect the next administration, whether it's a Biden or a Trump administration, to continue on that path. We may see some acceleration even more if it's a Biden administration because, they were involved in passing the Affordable Care Act to begin with. And CMMI is their creation. And so, but either way, we expect these models to continue to grow.
I suppose also, one thing, it doesn't seem like we're going to go to Medicare for all, but if Biden were to implement lowering the Medicare age to 60, would that make a big difference for BPCI, for example?
Yeah. I mean, I think, we've consistently heard from CMS and CMMI that, they're pushing these programs out and they continue to push more programs. We're all learning. The Center for Medicare and Medicaid Innovation is the best healthcare think tank in the country. They're the most proactive in terms of actually creating real, new payment methods. That's been consistent from the Obama administration to the Trump administration. I mean, they've lost some people, frankly, in the Trump administration, but the leadership has still been good. And I think, not to get too partisan, but I do think one potential advantage of a Biden administration is, it will create more energy at CMMI, and they'll fill some of the positions that they've lost over the last 4 years and create a little bit more momentum there. But for the most part, they're pushing in the right direction, and anything that increases the population of people who are in these programs, which is, Medicare. If Medicare goes to 60, that'll be more people. Medicare Advantage has similar programs. And so, either way, we see real momentum.
So, Dave, I know you don't have much time for, anything other than work, not much time for politics, not much time for reading, but with the pandemic and, being around, not traveling these days, have you had a chance to read any books? Anything you recommend?
Yeah. I'm reading a really good book right now it just came out in September. I think it's called No Rules, about Netflix and Netflix's culture and the HR policies they have in place, which is just fascinating around, how candid they are, how much they focus on real-time feedback. They have this concept called talent density, which is, I think, a little controversial, but very intriguing. So I'm actually not quite through that book yet, but it's been profound, frankly, in the way I've been thinking about how we kind of grow and manage our business as we get bigger. I also just read The Everything Store about Amazon and kind of a biography of Amazon and Jeff Bezos. That was fascinating as well. I'm struck by, I think it was 2004 or 2005, they banned PowerPoint in favor of these 6-page narratives that they do, which I'm trying to write one right now, which is easier said than done, but kind of been immersed in both those recently. And I really enjoyed both of those.
That sounds good. You just need a Facebook and a Google book and you'll have the whole thing. And, a lot of people, Dave, you sort of up in people's game because a lot of people have been spending time on, during the pandemic on Netflix and ordering stuff from Amazon, but you've taken it a step higher.
Oh, no, I have plenty of that too. Find funny ways to waste time.
Well, Dave Terry, thank you very much. CEO and founder of Archway Health. We've been talking about value-based care, risk-based arrangements, and the 30 Years' War, which I guess may turn into 100 Years' War in healthcare. I guess at the outset, Dave, a few years ago, both of us were about the same age, about the same experience in healthcare. We're saying, well, I'm glad we're not in something like, fiber optics or something where the market could go away. And now there should be plenty to do for our career. And now I'm thinking, gee, as we're getting a little bit older, are we still going to have all these problems by the time we retire, or can we kind of chip away at them? So let's get heads down for the next 10 years at least and see what we can do.
I think there's plenty of work to do.
Yeah. Well, good. Excellent. Well, Dave, thank you very much.
Thanks, David. Appreciate it.
You've been listening to the Health Biz Podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.